Dear listeners, my name is Piret Paal and I welcome you to this 45-minute lecture about spiritual care. Before I start with my lecture, it is important to establish that my training is in anthropology, narrative medicine, and qualitative research. For the past 10 years, I have put lots of effort into advocating for better access to palliative care, in particular concentrating on enabling training in this area to healthcare professionals in WHO Euro region. I am fully aware that for many lay and professional people, palliative care still equals the end of life care. Hence, it is important to point out that when palliative care is mentioned in my speech, I refer to integrated palliative care services that can be provided to young and old at any stage of illness by all healthcare providers and not only specialists. As you may imagine, the subject of spiritual care in healthcare is controversial for many reasons. There is very little evidence about spiritual care for patients with neurodegenerative diseases. I have conducted recently a literature research on this subject, and here I try to put these findings into a broader framework of global health, so please bear with me. In the preamble, I shall use the example of epilepsy to set a context to some issues that will be discussed in the later parts of my presentation. Then I shall reflect shortly on the history of spiritual care in modern healthcare. As it is important to be on the same page, I shall introduce you to the available definitions, and then we will look at spiritual care in palliative care with a special focus on neurological conditions. By the end of this lecture, you should be able to grasp what is known about spiritual aspects of care, why does spiritual capacity matter, and the most burning question possibly, are there any assessment tools? Epilepsy is one of the oldest diseases documented for almost all Asian cultures. In therapy, magic healing rites have played a central role for a long time. During the Corpus Hippocraticum, epilepsy gradually began to lose the image of sacred disease. However, in the Middle Ages, exorcism still held a privileged position alongside herbal remedies to treat the falling sickness. Persian Dr. Avicenna was the first person in medical history to use the term epilepsy, meaning possessed by an external force in Latin. In his influential work, The Canon of Medicine, Avicenna lists several well-known plants such as French lavender, coriander, or majoram, used as anticonvulsants, suppressing convulsions, characteristic of the disease. Throughout history, different cultures across the globe have used shamans or medicine men and women to heal patients that have been identified as possessed by an external force. Here you see Tubiaku Kosterkin, who lived from 1921 to 1989, who was probably the last great Nkanasan shaman. His father, Tukhaid, was already well known among the researchers of shamanism. Several books have been published describing his cleaning rite of becoming a shaman. Many scholars have asked why and how shamanism works. I will try to make a very little summary here. In healing rites, the shamans use special words and sounds, strong herbs and drugs, and their main function is to put the patient back on their right track. The shamans are the mediators between the spirit world and the community. An important part of such healing rites is the performance which besides the shaman, their helpers, and the patient also always requires observers. Because illness is never a personal or private problem, it is typically interpreted as a problem of the community. And as the Tubiakos incantation indicates, at the end, the god's pattern shall become visible. Among other world religions, Christianity is perhaps the most binary one. There are good and bad spirits, the worst of all being the devil. You are probably familiar with numerous paintings that demonstrate Jesus healing a boy suffering from the falling disease. And we have heard how in the Middle Ages, priests exercised exorcism on people who believed to be possessed by the devil. So it may come as a surprise that Pope Francis has paid special attention to demons, warning his flock to look out because the devil is present. In 2014, an exorcism conference at Vatican addressed the need for more demon-fighting priests. The International Association of Exorcists has approximately 300 exorcists working across nations. Pope Francis has lauded the group for displaying the Church's love for those possessed. The spokesman of this association, Walter Castioli, told Vatican Radio that there has been a steady increase in the number of people turning to demonic practices, and they are left suffering from serious spiritual and psychological damage. This slide could be difficult to look and listen to, but when we return to what is called the natural sciences, there is an important time in the history of medicine that should never be forgotten. In 1939, a 6-year-old girl, Hildegard Mertens, is declared an idiot because of epilepsy, taken from her parents and killed. Another victim, Otto Matthews, who in 1921, at the age of 14, had entered Woolgarten Sanatorium at his parents' wish, was sterilized in 1935 and murdered 5 years later. The basis for these actions was a decree by Adolf Hitler, which gave doctors the right to grant mercy death to incurable ill patients. These horrible events resulted in the Nuremberg Code and the Declaration of Helsinki, documents contributing to medical ethics and stressing the values such as respect for autonomy, non-maleficence, beneficence, and justice. These are acknowledged tenets in modern medicine that allow doctors, care providers, and families to create a treatment plan and work towards the same common goal. In this preamble, I highlighted some approaches to manage epilepsy, one of the oldest diseases documented. Only since 1960s, we can speak of medical treatment of epilepsy. Today, there is a significant mismatch between the available and accessible specialized neurologic services and the requirement for them. Neurology training centers are few, and the availability of laboratory facilities and equipment is limited to metropolitan areas. Also, health insurance is not available for the majority, with patients having to bear the cost themselves, thus limiting the procurement of healthcare facilities. This leads to a loss of faith in healthcare systems and the use of unproven interventions, which create new health risks. On top of everything, cultural practices, superstitious beliefs, ignorance, and social stigma impede the delivery of neurologic care. We all are aware of how complex the issues around health and healthcare systems are. At the beginning of my presentation, I wanted to add an anthropological historical layer to this already complex issue, which hopefully helps to contextualize why health is more than the absence of illness. Let us move on further to take a look at how the thought around modern spiritual care has developed. I want to begin this part of my presentation with a question. When people suffer from pain and other symptoms, it is not spiritual care they need, or is it? I invite you to a little journey to see this question from a historical perspective and of the present time. I believe, and this is my personal opinion, that spiritual care is a domain that should be incorporated into health prevention, promotion, and rehabilitation more widely. However, in this talk, I will concentrate on spiritual care and palliative care. Here is a devastating fact to start. According to Lancet Commission's report, the global divide in access to palliative care represents a dreadful social injustice. There are almost 300 million metric tons of morphine-equivalent strong painkillers distributed in the world each year. Only 0.1 metric tons are distributed to low-income countries, and 50% of the global population. We speak here of 3.6 billion people who reside in the poorest countries receive less than 1% of the morphine distributed worldwide. So, quite bluntly, if the material component is not available, what can a professional involved in caring for the severely ill offer to reduce the illness-related suffering and to maintain not only their quality of life, but give meaning to their suffering? In many countries, well-trained oncology nurses are leading palliative care services in hospices and communities. So let us look at spirituality in nursing care. The Kaiserswerth Nursing School in Germany has been called a forerunner of professional nursing education. In Kaiserswerth, a place where young Florence Nightingale was trained, the nursing of the soul, caring for the spirit of the sick person, was given equal importance to the care of the physical body. The Kaiserswerth sisters took care not only of the patients, but also of their family members. They cooked, took care of children and siblings, and provided personal and spiritual support for all involved. Sometimes the mere presence of a nurse appeared to have had a soothing effect on the sick and their family. The modern multidisciplinary palliative care, recognized by WHO, has emerged as an innovative field of intervention in the 1980s. Initially, palliative care was focused on cancer pain relief, including some public health values. Back in the 1980s, the palliative approach was reasoned low cost but capable of producing big effects. To reach the highest potential education of the public and professionals, changes to legislation and prescribing practices to guarantee drug availability and supporting the other measures via governmental policy making were defined as principal challenges. In 1990, in the technical report of WHO, pain relief methods were still very much emphasized. However, in the spirit of broadening the scope of approaches and in line with the holistic orientation of palliative care, addressing other physical but also emotional, social, and spiritual needs were included in the recommendations. This WHO report has become a landmark in the history of palliative care. In this report, palliative care became framed as a global public health issue, defined as the active total care of patients whose disease is not responsive to curative treatment, control of pain, other symptoms, and psychological, social, and spiritual problems is paramount. The goal of palliative care is the achievement of the best quality of life for patients and their families. In 2018, 28 years later, the Astana Declaration's commitment to prioritize disease prevention and health promotion to meet all people's health needs across the life course through comprehensive preventive, promotive, curative, rehabilitative services and palliative care still challenges governments to expand hospice and palliative services provisions from the private sector to the public sector, all the while maintaining quality person-centered care. The Astana Declaration calls organizations and advocates to redouble global efforts. Unfortunately, there's still plenty of regulatory barriers that limit prescription, dispensation, and administration of strong painkillers in primary care, which cannot be removed without a strong commitment from governments. Furthermore, there is a great need to strengthen palliative care education to achieve integration. Universities, academia, and teaching hospitals need to work on including basic palliative care training and modules adapted to the principles of primary care. So now let's look at the concepts. Parallel to the developments in palliative care, a global consensus has been reached among key stakeholders that spirituality is an important component of health and should be integrated at all levels of healthcare. Such views endorse the biopsychosocial spiritual healthcare model. Apparently, it was a close call that the notion of spirituality did not become a part of the WHO definition of health already in 1948. When the WHO revisited the definition of health in 1984, the notion of health was conceptualized as a resource and resilience for health promotion, well-being, and living, namely, the extent to which an individual or group is able to realize aspirations and satisfy needs and to change or cope with the environment. Accordingly, health is a resource for everyday life, not the objective of living. It is a positive concept, emphasizing social and personal resources as well as physical capacities. This definition aims at attaining a health strategy that has both a material and a non-material component. In 2020, the EAPC white paper on spiritual care education in palliative care was published. This document points out the importance of spiritual care as an integral part of palliative care and suggests incorporating it accordingly into educational activities and training models in palliative care. The white paper claims that better education can help the healthcare practitioners to avoid being distracted by their fears and restraints and attend to the patient and their family. This white paper stresses that spirituality is multidimensional, consisting of existential, value-based considerations and attitudes, and religious considerations and foundations. However, it is critical to comprehend that in care situations, it is the patient who tells us the form their spirituality takes. Patients may not use the term spirituality, hence listening carefully to the patient's vocabulary is of major importance. I recently studied the perceptions of palliative medicine physicians in Israel, which is a cultural and religious melting pot. What they expressed was fascinating. The interviewee stressed that spirituality is a broad term which includes more than just religion. I quote, In Israel, there is some sensitivity about religious issues, bringing religious issues maybe to people who are not so interested in this. So for some people, spirituality is religion, but for others, it's maybe literature, poetry, music, People have different spiritual needs. End of quote. Besides working together with broadly educated hospital chaplains who care for patients from all major religions, spiritual assessment is seen as a crucial part of patient-oriented care. I quote, "There is not a single patient that I don't ask about his spiritual beliefs. It is important. What does death or disease, first disease and then we come to death, mean for him? What does it mean for you to be ill? Somebody feels it's a punishment, and somebody feels, how do I get this? This is that. And somebody thinks, I have a lot of women here who say it's my bad marriage. I have a lot of men who say it's my work. I want to hear all this because if I want to help them, we need to. I need to work with this." End of quote. What is the current state of knowledge and evidence regarding implementing spiritual care and palliative care? There is some good evidence that spiritual care training is perceived by healthcare providers as a positive awakening and eye-opening intervention. There is even some evidence that a well-planned and professionally conducted spiritual care training with clear goals and competent faculty may help to challenge the spiritual vacuum in healthcare institutions. However, caution and knowledge are needed when planning such educational interventions. The evidence confirms that without attending to one's own beliefs, values, and needs, addressing spirituality and providing spiritual care will not be forthcoming. The lack of vocabulary to discuss spiritual care comfortably is a huge challenge. It is a component that must be part of breaking bad news training, but equally important is to teach that one cannot discuss deeply personal matters with someone who is not invested, avoids eye contact, and is not there. It is known that after the training, many questions still must be answered. Is it okay to address spirituality in practice? Is it my role to assess spirituality? When do I take spiritual history? How do I make the situation comfortable? What if the patient doesn't want to discuss spirituality with me? Like all other clinical practices, spiritual care training needs bedside practice and mentoring. Hidden curriculum and hostility affect the transference of personal attitudes towards spirituality into the professional context. The void in healthcare professionals points out the central role of organizational and management culture as an enabler of spirituality and spiritual care. Indeed, healthcare professionals' unwillingness to engage in discussions surrounding spiritual needs is largely rooted in organizational influence and culture. The focal critique across the field of health and allied professionals is that the clinical environment does not support the inclusion of a spiritual dimension in an assessment and treatment of spiritual issues, and spiritual care is neglected in favor of physical care. The challenge in palliative care is to build spiritual capacity. For example, nurses from German-speaking Switzerland largely agree that the essence of spirituality is being mindful of oneself, one fellow humans, and the world. I very much like this definition because it's calling for giving space. In German, it's called Raum, for expanding the spiritual capacity on intrapersonal, interpersonal, and organizational level. Developing a spiritual capacity comes down to narrative, meaning-making, seeking, and possibly finding explanations to life questions, which, according to the French philosopher Paul Ricoeur, is always a mediation between man and world, between man and man, and between man and himself. This, of course, applies to women as well. Being able to make meaning on these levels helps us to move from void to capacity. which on the other hand means that it enables personal growth. This again supports the ability to comprehend that the things we do and say, or avoid doing and saying, matter. We equally learn that not doing and just being can be an empowering asset, helping those who, because of their health-related suffering, are losing their identity, faith, and value as human beings. Let us come back to the opening question. When people suffer from pain and other symptoms, it is not spiritual care they need, or is it? Historical evidence and global advocacy suggest that when people suffer from pain and other symptoms, they do need spiritual care. According to WHO, in particular, non-material social and personal resources must be utilized so that people can best cope with physical limitations. In 2019, Benzi Kluger invited us to write an editorial about Parkinson's patients' spiritual need. This task revealed how little is known about spiritual needs in this patient group. So, in our research group, we decided to conduct a literature review which highlighted how, in particular, patients with motor neuron disease and neurologic disorders could benefit from early integration of palliative care, including spiritual components. Here you see an integrated spiritual care model for patients with neurodegenerative diseases and their caregivers. This model is based on an extensive literature search looking into the evidence regarding the spiritual care needs with this population. The comprehensive care model consists of 4 main pillars. Firstly, the initial talk, what to expect. The new science of prognostication, the estimating and communication, what to expect, is in its infancy, and the evidence base to support best practices is lacking. Across the world, cultural practices, superstitious beliefs, ignorance, and social stigma impede the delivery of neurologic care. Honest communication about uncertainties over prognosis and the impact of interventions and assertment of individuals' values and beliefs make for better care. Hence, formulating a prediction and communicating what to expect with patients, families, and surrogates in the context of common neurodegenerative diseases is of major importance. Secondly, monitoring the changes and negotiating. The idea of being incurably ill and dying must be continuously negotiated. This continuous negotiation must take place between the healthcare providers, patients, and caregivers. It has been estimated that the spiritual needs change during the progression of disease, also due to brain degeneration. In this regard, not only clinical work, but research in spiritual care for patients with neurological diseases has to be capable of capturing the stages of bodily failure, changes in self, feeling of not belonging or being a burden. This all to prevent distress, suffering, and pain, as well as loss of faith, particularly in healthcare systems. Thirdly, preventing isolation and demonstrating belonging. To prevent isolation and demonstrate belonging, inquire about patients and caregivers' social connections and support networks. If patient and caregivers fail to identify such support, share information about patients' associations, support groups, consider providing healthcare provider or volunteer home visits, or maintaining regular contact via telehealth services. Finally, legacy work at the end of life. Legacy work where patients' biography is told, written down, edited, and exquisitely bound as a keepsake is gaining ground in palliative care. Nearing the end of life, spiritual legacy work and dignity therapy may be provided by healthcare spiritual care workers. However, Each healthcare worker is in the position to promote spiritual well-being and dignity in dying by encouraging patients to articulate their preferences and learning to listen to what they say. Now, let us have a brief look at the middle field of the integrated spiritual care model. A number of scientists have tried to locate the spirituality and religious beliefs in multiple brain areas. As I am not a neurologist, it is probably best if you familiarize yourself with this literature. But the evidence demonstrates that neurodegenerative disorders and other causes of brain damage can modulate religious and spiritual experiences. Knowing that changes in the brain may modify patients' beliefs and values, it is important to consider spirituality and religious beliefs whilst caring for people with neurological diseases. Somewhat surprisingly, in many regions across the world, the belief in supernatural factors as a cause for neurological and psychiatric illness, including the evil eye, divine testing, punishment, and sorcery, is still very much prevailing. For example, a patient with epilepsy unfortunately still is considered to be unclean, touched by evil forces, and contagious. And at other settings, the sick person suffering from such disorder can be considered divine magic, able to utter prophetic oaths. Even without demonizing the illness, the diagnosis of neurodegenerative disease is devastating for patients and their families. It challenges the patients emotionally, compromises identity, limits their independence, and forces patients and their caregivers into social isolation, and therefore threatens the ability to find meaning and purpose in life. People feel overwhelmed to the diagnosis, experience fear because of the uncertainty the future holds. Personal beliefs and distress affect patients and caregivers' illness experiences alike. Compared to those with chronic liver disease, patients with epilepsy had limited understanding of the illness and poor belief in personal control and treatment control. They had a negative emotional response to their illness and were afraid of the effects on the patient or the patient's family. Existential dangers and uncertainties worsen patients' illness experiences, even if good clinical care is available. A true challenge for people with neurodegenerative diseases is maintaining a sense of self in the context of neurological condition. Patients cannot be left alone with the feeling of losing themselves. Patients' narratives report on 3 stages of bodily failure that affect self-perception. According to Harris and colleagues, these 3 stages are body failing prematurely and searching for answers, body deterioration and responses to care, and body nearing its end and needing to talk. Penner and colleagues suggest that care must attend to the deep needs of these individuals by communicating in a style that addresses both emotional and cognitive needs of patients by thorough and holistic assessment and by appropriate referrals. Unmet needs are generally seen as issues of concern for which the individual perceives they require assistance. To determine someone's needs means considering his, her, or their values and preferences, previous and current wishes, and advanced stages of disease, consultation with families and other caregivers. Studies on patients and caregivers with neurodegenerative disease report on various unmet needs that may lead to the loss of faith and spiritual distress. If the needs are unmet, people lose faith not only in higher transcendent powers but also in the local healthcare system and especially in the neurologist responsible for diagnosis and care. This may force them to seek treatments in other countries, which often relates to false promises and broken hopes. As the preamble of this talk indicated, the Spiritism philosophy is being spread worldwide as a complementary treatment to neurological disorders, particularly epilepsy and mental health issues, and is often executed by faith healers or traditional healers. Spiritual well-being is a source of happiness or unhappiness and subsequent well-being for people. Studies have shown that spirituality is a key component of overall well-being, and it assumes multidimensional and unique functions. The impact of spiritual well-being on decision-making is evident. Individualized care that promotes engagement in decision-making and considers patients' spiritual capacity is essential for promoting patient empowerment, autonomy, and dignity, which are required by the medical ethics guidelines mentioned in the beginning. Enhancing spiritual well-being must not be complicated. For example, meal times that make patients feel comfortable and homely are part of existential care that leads to positive experience. In health-related discussions, people often forget that spirituality is the source of joy and enjoyment that sometimes may cause suffering, distress, and pain, and not the other way around. Interventions to foster positive living with neurodegenerative disease in clinical practice should integrate strategies to tackle and prevent loneliness and interagency elements to increase community resources and systems of support. Support group intervention programs enhance the meaning making of participants' subjective experiences and help to define purpose in their lives. Caregivers cope with the unpredictability of caregiving demands through reflection on personal faith beliefs that value a focus on the present rather than an unknown future. Religious involvement, which typically contains a strong element of group support, is associated with better caregiver adoption, at least in female caregivers. The search for religious support is, however, associated with social determinants such as education and economical status. A small exploratory study from Austria indicated that caregivers felt relieved and comforted when their care-dependent relative moved into a nursing home. The feeling of not being solely responsible for the patient's health status, hope that the patient receives good care, and sometimes can participate in social activities contribute to the feeling of being supported and belonging. Globally, the low number of care facilities combined with high out-of-pocket payments, long waiting lists, and limited supplies make it difficult for caregivers to use such supportive offers. To summarize, in the 1960s, the UK hospice movement enriched medicine with the notion of spirituality as an important aspect of the total pain concept. Nurse, social worker, and physician Dame Cicely Saunders fought for cancer patients' integrity, uniting the best care practices from nursing and medicine and developing an Ars Moriendi model maintaining pain relief through ample dosing of morphine. Since 1991, international efforts have been made to improve spiritual care not only in palliative care, but also in healthcare in general. In 1996, spiritual suffering and distress were listed at the NDA Nursing Diagnosis Guidelines. In 2006, WHO endorsed spirituality as health-related quality of life indicator. In 2012, the International Council of Nurses stated that in providing care, the nurse promotes an environment in which the human rights, values, customs, and spiritual beliefs of the individual, family, and community are respected. The problem is that spirituality is rarely promoted as an integral component of health and well-being in public health and/or patient education context, which means that patients and caregivers are equally confused when healthcare professionals, often unexpectedly, address their liberty to express spiritual topics in the secularized context of technical medicine. Spiritual care is defined as a generic healthcare function equivalent to emotional care or physical care, and thus non-discipline specific. That means that all healthcare professionals carry the responsibility for spiritual care provision and maintaining connectedness. It is known that healthcare providers acknowledge the importance of spiritual care, yet What is involved in providing the care remains unclear. Help is sought from developing assessment tools and the instrumentalization of spiritual care. How current instruments designed to measure spirituality-related aspects serve the MND population is not clear. Clear is that these tools are trying to identify deficits and not map the individual spiritual capacity that could be obtained to cope with the disease. Patients, however, do not emphasize a need for spiritual interventions. Most of them express their gratitude for feeling listened as a whole being instead. The available evidence in this area of research and clinical practice is extremely limited. What is known so far? In neurodegenerative disease, spirituality can change depending on an individual's perception of self, personal aspirations, unmet needs, and other possible life stressors, such as self-perceived loneliness or financial concerns. This points out the significance of the ongoing conversation about spirituality, which allows the patient to express his, her, or their beliefs and values. Such conversations establish a connection between the patient, caregiver, and healthcare provider. A conversation about spirituality is to be seen as a crucial first step in establishing a therapeutic relationship which prepares the ground for screenings and clinical assessments that take place at the same time but cannot replace the conversation. Palliative care is a human right, and making palliative care accessible is a global endeavor. It is a heinous social injustice that access to pain medication is a privilege of those living in the urban settings in few selected countries. This, however, does not necessarily mean that billions of people are left without care. Comfort care is multidimensional. Even if the material component is missing, we still have the solace provided via human connectedness, a non-material component able to soothe the social, emotional, and spiritual concerns. However, the human component is precious. At the times when many have lost their faith, where 50% of nurses think of leaving their jobs, healthcare chaplains experience spiritual cool down, physicians suffer from burnout, and the suicide rates among healthcare professionals are rocketing, measures to support staff in workplaces are of utmost importance. This calls for spiritual leadership and implementing of value ethics also in healthcare organizations. Thank you for your attention.